with mitral regurgitation, you're going to have both acute and chronic MR. The difference between the two is that with acute MR, you're not going to have a dilated left atrium because it didn't have enough time to dilate. It's like when you spring a leak somewhere, you know, the area is not going to be flooded right away. It takes a minute. So if you're asked anything about, you know, you have a patient who has, you know, normal sized left ventricle, normal sized left atrium, they have severe MR, and and like the left ventricle was hypercontractile. How would you know the difference between acute and chronic? And acute, you'll have a normal sized left ventricle, normal sized left atrium, and you're going to have a highly contractile left ventricle because you have that more volume overload. Whereas chronic, you will have left atrial dilatation, your left ventricle will be dilated, you'll have some systolic dysfunction, and pulmonary hypertension. So what causes MR? The most common cause is rheumatic disease, endocarditis, and mitral valve prolapse. These are the most common primary causes. So anything primary is relating to the mitral valve itself. The mitral valve has been compromised, the mitral valve is diseased, and has nothing to do with anything else, just the mitral valve. So that's the primary cause. The most common secondary cause, or the most common secondary cause of regurgitation is mitral annular dilatation. So when the mitral annulus expands, it gets dilated, the mitral valve leaflets or scallops lose the ability to coapt normally. So the scallops and the leaflets will still have the chordae tendineae that will kind of stop the mitral valve from prolapsing, but there's still going to be areas right between where it would coapt, where blood is going to be able to freely move through and go into the left atrium during systole. So in this diagram, what we do is we use continuous wave Doppler, and we just run that through the mitral valve, and we get a peak gradient where we can measure the VTI, the MR VTI, or just caliper the peak gradient. And this will be below the baseline. This right here, when you have MR kind of, instead of going straight down centrally and it's kind of like hugging the wall, this is called the Koanda Effect, where blood will kind of swirl along the sides of the left atrium and then come back up. What we do is we're going to use pulse wave Doppler and place the sample gate or sample volume in the pulmonary vein, the right upper pulmonary vein, and we're checking to see if there's any flow reversal during systole. If you have a blunted signal in the pulmonary vein and there's MR, it's probably not going to be severe. But we will know for sure it's severe if it's reversed, because in systole, blood will be coming down into the left atrium and then impinging on the pulmonary veins, causing the blood flow from the lungs to be reversed. Does that make sense? This is important to know.
Yeah. What did you say one more time about the flow reversal? If it's below the baseline, then that means what?
Yeah. So to determine if mitral regurgitation is severe or not, we use pulse wave in the right upper pulmonary vein. And if it's reversing during systole, it's probably severe. Because this waveform should be above the baseline and taller than the D wave. The S stands for systole, D stands for diastole, and the A stands for atrial kick. So this here is normal. The atrial kick is normal. That should happen. but this should not happen.
Okay.
Good on that?
Okay. Yes.
Cool. So here's an example of a sonographer, measuring the MR and getting the mean and peak gradients. Okay, let's go to, and to save time, it's going to be the same for TR.
Right.
But with TR,
okay,
the one thing you have to do to determine if it's severe or not is you have to run your pulse wave in the hepatic vein. And if you have systolic reversal in the hepatic vein, it's most likely going to be severe. What's cool about PISA is that if you want, you could perform PISA on the flow going from the left atrium to the left ventricle if you just turn up your baseline.
right.
So if you're looking at stenosis, you want to turn your baseline up instead of down. So you can turn it up, and then you'll get these high velocity PISA shells here, and you'll measure the PISA shell here. You'll measure the diameter of the PISA shell from here to here. So here's a cool little diagram of the PISA shell. If for this image, you would turn your baseline down for the record. You always want to turn your baseline towards the PISA. So the PISA is going down here. So on the baseline, you would turn it down. On this image, you would turn your PISA up because the PISA is going up. Make sense?
Yes.
Here, you would turn your PISA down because the PISA is going down. So with MS, you're going to have weird symptoms that might come up on your boards, such as hemoptysis, and that's where patients will cough up blood. So you can determine mitral valve stenosis a number of ways. The least accurate way is by planimetry, and that's where you would get your short axis view at the mitral valve level. You would scroll to where the mitral valve is opened, and you'd pause it, and you would trace the inside of the orifice, right where the bright area interface meets the darker interface. The most accurate way would be to run your continuous wave Doppler through the mitral valve. You would measure the VTI above the baseline. You would get your decel time, and you would compare it to your chart here. If you want to calculate the mitral valve area with just the decel time, you'll take this number 759, which is constant, and you'll divide that by your decel time. That'll give you the mitral valve area. Or you can get the pressure half time by timesing 0.29 by your decel time. This is a constant, and this will give you your pressure half time. You'll have to know this for your boards.
Right.
You take your pressure half time, and you'll divide that by 220, which is a constant. When we're looking at mitral stenosis and we want to measure a decel time, you got to be very careful that you don't measure it incorrectly. For instance, 1 and 2, these are both incorrect. If you were to measure it like this, you would underestimate the severity of mitral stenosis, and you would overestimate the mitral valve area. Same thing with this one here. You see how like the waveform kind of comes up here, peaks here, and then will come slope down, and then we'll stop and then start a new slope here.
Yeah.
This would be the most accurate way to measure inflow waveform. Incorrect.
Okay.
Incorrect. Very correct. Okay. So aortic stenosis, what it does to the heart, the pathophys is, well, you're going to have LVH. You're going to have a concentric hypertrophic cardiomyopathy. I should put that in there, concentric. LVH. You're going to have an increased afterload, which is pressure in the left ventricle after systole.
Okay.
Or during systole. I think it's during systole. During. There we go. And you'll have anemia as a result. Why do we get anemia from aortic stenosis? Well, so anemia is when you have a decreased amount of red blood cells in your body. And if you have an area, like in your heart, specifically the aortic valve, that's stenotic, you're not going to get the sufficient amount of blood or red blood cells to meet the metabolic demand. So they become anemic because they're not getting as much. And that's why, you know, patients with aortic stenosis, they get dizzy, they get short of breath. I don't know why I don't have that in here. I should put that. Of course they get dizzy. The most common cause of aortic stenosis is just a calcified bicuspid aortic valve. It's most common.
Okay.
Do you remember back in the early 2000s, late 90s, when doctors were prescribing fen-phen? Fen-phen was very popular in its day because you could lose weight so quickly. But there's a drawback. And what happened was physicians were noticing a lot of patients who were having heart problems while they were on fen-phen. So after like, I don't know, 6 months to a year, when they figured this out, they took it off the market. And some patients didn't feel effects, but a lot of patients suffered a great deal of heart problems, mainly valvular calcification leading to stenosis, and then it's just a downhill from there. But also, so congenital, bicuspid, unicuspid, and rheumatic. But the most common is the calcified bicuspid aortic valve. Signs of aortic stenosis, like I said, LVH, it's important to know. It's not only important to know that obviously the valve is narrowed or calcified, but what else it does is it causes LVH and afterload, as well as a hyperdynamic functioning left ventricle. So it's gonna work harder. It's gonna squeeze harder, which makes it thicker. We have some congenital conditions. This is a sub-aortic stenosis. This is a membrane. The aortic valve's here, and this is a little membrane that's kind of causing a narrowing here in this LVOT. This is a supra-aortic stenosis with these membranes here. This is associated with Williams syndrome. So you'll have an abnormal aortic valve septal separation. The normal measurement is anything greater than 15 millimeters, or in centimeters, 1.5. Make sure I have that there. Abnormal is less than that, 15 obviously millimeters. So this would be abnormal, normal. What else? What do we need here?